Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Hi, I'm Dr. Roy Jensen, director of the University of Kansas Cancer Center. A diagnosis of breast or prostate cancer can be scary, but here at the Cancer Center, we want patients to take time to allow providers an opportunity to map a treatment plan that is right for them and their unique cancer. The goal is always to provide the right treatment at the right time with the least amount of exposure to toxic cancer therapies such as radiation and chemotherapy. Research is increasingly showing that less is more. We call this de-escalation of cancer treatment. So joining us today are Dr. Xinglei Shen, a radiation oncologist, and Dr. Qamar Khan, a breast medical oncologist. Well, thank you both for being here. And let's start by defining de-escalation. What does that mean in terms of cancer treatment? So
So we all know that cancer treatments are associated with toxicities or side effects, and sometimes these side effects can be a lot. De-escalation is a strategy to limit the amount of those side effects, in other words, to avoid unnecessary overtreatment of breast cancer. The biggest, I think the most historic example of de-escalation of treatment is transition from radical mastectomy to lumpectomy plus sentinel lymph node biopsy. For a century, surgeons were doing this radical operation where breast was removed and muscles in the chest wall were removed and all of the lymph nodes in the axilla were removed, and it was a very traumatic experience for the patient with long-term disability. And through research and de-escalation, we learned that a simple operation such as lumpectomy with removal of a couple of lymph nodes known as sentinel lymph node biopsy achieves the same goal of cure, so same level of cure without increasing the side effects and morbidity to the patients.
Mm-hmm. Yeah. So Dr. Shen, how does de-escalation work in radiation therapy then?
Sure. So I think with radiation therapy, historically, what we've always tried to do is maximum amount of treatment, and we'll deal with the side effects later. But now we're increasingly aware of the biology of different cancers. They behave very differently. And so we're very, as we get into the biology of cancer, maybe they don't always need such a high dose of radiation, and we can have a very high cure rate even without it. Or also, it's different strategies how we give the radiation. Mm-hmm. So for instance, in prostate cancers, we know they're very sensitive to how much radiation you give each treatment. And by changing the amount you give each treatment, sometimes we can get away with much less total dose, and shorter treatment times. So just on the topic of de-escalation, one of the great examples of this is seminomas, which is a kind of testicular cancer. Mm-hmm. That historically in the 60s, 70s, 80s, we were doing high doses, moderate doses of radiation for adjuvant treatment, so after surgery, to prevent cancer from coming back to the abdomen. And then in the 90s, we figured out, you only need to give half the amount of dose. Mm. And today, we don't give any dose at all, because we know that we can monitor these patients very closely, and if they have a recurrence, we can still go back and treat them, have the same cure rate. So now we've kind of gone from lots of side effects to, for most people, no side effects.
Mm-hmm. So, Dr. Khan, you already gave the example of the transition from radical mastectomy. How else has the concept of de-escalation impacted how we treat breast cancer?
So I view breast cancer as two different stages of breast cancer as a broad group. So early stage breast cancer and metastatic breast cancer, or stage 4 breast cancer. For early stage breast cancer, the goal of the treatment is to cure the cancer completely, so that the person is able to live their life normally after the treatment of breast cancer. And de-escalation in early stage breast cancer is designed to prevent long-term toxicities. For example, there is a drug in breast cancer called adriamycin it used to be a necessary evil in breast cancer because it causes leukemia and heart problems in a small number of patients. So through de-escalation, we have found ways to replace those that drug associated with long-term side effects with targeted treatments that are like laser-guided weapons that target only the breast cancer cells. So this is the main way we try to de-escalate in early-stage breast cancer. In advanced breast cancer or metastatic breast cancer, the goal of the treatment is not to cure the cancer, but to prolong the person's life as much as possible, and also make sure that they are not having side effects from the treatments so that they can live their life normally with a good quality of life. And in that setting, we try to find new schedules and doses of chemotherapy so that they are able to control the cancer at the same rate and not have the side effects so that they can live their life. Mm-hmm. So one example of that is oral chemotherapy called capecitabine or Xeloda. And we all realized that the FDA-approved dose is too high for the patients. It would control the cancer, but make the patients miserable, and their quality of life was severely impaired. Mm-hmm. So we have developed a clinical trial where we are looking at a different dose and a different schedule of the same drug, and we are seeing good results with the patients living their life with a much better quality of life, achieving the same results.
Mm-hmm. So Dr. Shen, obviously not all patients mm-hmm. are going to be candidates
Sure.
For some of these de-escalation strategies. How do we go about determining, who's eligible for hypofractionation or so-called SBRT?
Yeah, sure.
And how is that appropriate for a select number of patients?
So more and more we're doing hypofractionated treatments, and it's been established as standard of care. And the reason why has been is because of clinical trials. We've tested this, and we've proven that these are equivalent to the old standards, mm-hmm. which we'll always compare to. And so it's not appropriate for every cancer site, every cancer stage, because we haven't tested it. But that's why clinical trials are so important. I'm very proud to be involved in clinical trials, and we do a lot of that type of treatments. Clinical trials designed to be as safe as possible for patients who are going to participate in those trials, and that establishes new knowledge for us, so that in the future, these shorter treatment courses and de-escalated treatment courses can become the standard of care. Mm-hmm. So if there's not a established data, everything we do is based on data and information. If there's not established information, we won't just willy-nilly do a treatment we think might work. We have to prove it first.
Mm-hmm. So in your world, Dr. Khan, how do we go about selecting patients for potential de-escalation?
So we are able to test the cancer in a much better way now. The basic testing that we do for cancer consists of 3 markers that we test: estrogen receptor, progesterone receptor, and HER2 receptor. And based on those markers, we decide about the treatment. But we actually are able to test the cancer by genomic profiling. So we look at the expression of cancer genes, and we have now tests that look at the expression of the gene, and based on the expression of the genes, we are able to actually tell if the patient needs chemotherapy or not. So in a huge group of patients, the biggest group of patients with breast cancer is hormone receptor positive breast mm-hmm. cancer. And because of this genomic test guidance for the need of chemotherapy, we are able to spare chemotherapy in more than 70% of the women who would receive chemotherapy with side effects 10 years earlier. Mm-hmm. So now we are able to test the cancer genomically to find the patients who actually need chemotherapy, and also find the patients who do not need chemotherapy with excellent outcomes. Mm-hmm. Another strategy that we are using, which is more of a novel strategy, and we are using it in clinical trials here at KU as well, is to give treatment, endocrine treatment, which is associated with much less side effects before surgery, and see how the patients respond to anti-hormone or endocrine therapy. And based on that, decide if the person would need chemotherapy after surgery or not. Because if the cancer is very sensitive to anti-hormone or endocrine therapy, they are not going to be needing chemotherapy after surgery. So these are the strategies that we use for de-escalation of treatment, achieving the same cure.
If you're just joining us, we're here with KU cancer specialist Dr. Xinglei Shen and Dr. Qamar Khan, and we're discussing de-escalation approaches in cancer treatment. Cameron Poindexter is here in the studio to take your questions, and remember to share this link with people you think might benefit from our discussion. Use the hashtag #BenchToBedside. So Dr. Shen, how have these treatment advances or de-escalation strategies improved patient outcomes?
Sure. So I was at a symposium a few months ago. We were talking about how my prostate cancer treatments have changed in the last 5 years. And I put up a slide where what I did 5 years ago, everybody got the same dose, 9 weeks. You know, it's very inconvenient. And now we have so many more strategies for treating these patients that are standard and experimental. And so what we've gone from is one size fits all to a much more personalized approach for each patient, saying, you know, going from 9 weeks to 5.5 for some patients, 5 treatments for some patients, no treatments for other patients. And what that has done is allowed patients to be have better quality of life by shorter treatments, less inconvenience, and able to just get on with their lives easier. We also think, and as we continue with these treatments, we also think these may actually be more effective, some of these shorter course treatments.
So recently it was announced that we're going to be building a Proton unit here on this campus. Tell us a little bit about how that may impact selection for certain therapies in cancer.
It's going to be a game changer for us. I mean, Proton is a technology that we don't have in Kansas City that we need. And it's amazing to be part of this institution that's going to be building this Proton facility. The physics of protons is inherently different than that of photons, which X-rays, which is what everybody's been using for decades. The protons, the way it works is instead of the X-ray going straight through the patient, it goes for a certain depth and then it stops. And that allows different geometries that you can give to do the treatments. And the bottom line though is when you use protons, you may get less side effects for treatment. And that's I think we do a great job right now with prostate cancer treatments. When you add the protons in there, in addition to all the stuff we already do, I think it's going to make a big difference to patients in terms of side effects.
Okay. Dr. Khan, tell us a little bit about what's on the horizon in terms of breast cancer treatment, either in regards to chemotherapy or perhaps even immunotherapy.
So the breast cancer treatment is getting more exciting now, especially with the advent of immunotherapy in breast cancer. We know that immunotherapy is very helpful in curing patients with melanoma and lung cancer, but we are now recognizing that a subset of breast cancer known as triple-negative breast cancer is also sensitive to immunotherapy. So let me explain in layman terms what immunotherapy actually is. So body has an inherent mechanism of fighting cancer, and there is a type of cell in the immune system known as the T cell, and the function of the T cell is to scan and kill cancer cells. But the cancer cells are smart as well. So what they do is that they secrete substances that disrupt that scanning mechanism. So the T cells are blinded to the cancer cells, and they can't catch and scan and kill the cancer cells. So now immunotherapy is basically disrupts that mechanism that the cancer uses to stop the scanning of the cancer cells. And now the T cells are able to, because of the immunotherapy, the T cells are able to see and identify the cancer cells now. This is through a mechanism called the PDL1 pathway, and about 40% of the cancer, triple-negative breast cancers are PDL1 positive, and those are very sensitive to a combination of a light form of chemotherapy and immunotherapy with very few side effects. And the survival has changed. The survival is almost doubled in stage 4 triple-negative breast cancer by addition of immunotherapy to chemotherapy. We are fortunate that we actually have brought that advances in stage 4 breast cancer to early stage breast cancer and to see if it increases the cure rates. So my colleague, Dr. Priyanka Sharma, is a national expert in triple-negative breast cancer, and she has designed, and we are conducting a trial where we are looking at the efficacy or effectiveness of immunotherapy plus chemotherapy in early stage breast cancer to increase the cure rate of breast cancer. So this is a very exciting area right now in breast cancer.
Mm-hmm.
So you broached the topic of research and clinical trials, and obviously that's an extremely important aspect of why many patients come to KU Cancer Center. Could maybe each of you tell us a little bit about clinical trials that you've been involved in,
Sure.
or ones that you're involved in right now that you're particularly excited about? Maybe Dr. Shen?
Sure. Yeah, so we have trials ongoing right now that I'm very much involved in, both from national cooperative trials as well as the ones we've started here at KU. So national trials-wise, in prostate cancer, we're doing a trial comparing 28 treatments versus 5 treatments for prostate cancer. The idea that I think ultimately what's going to show is that the 5 treatments are better, and that's going to become the new standard of care. Another one in the theme of de-escalation is switching out the hormone treatments that we combine with prostate cancer, switching out what we currently use for one that's has less side effects. A pill you can stop any time, side effects go way faster. So that's another national trial we're in. We've also developed trials here. And one of the trials we have ongoing is, instead of 5 treatments, just 2 treatments, 2 external beam treatments for prostate cancer, so much faster and more convenient for folks. We're also developing a trial where we increase the radiation dose and allowing us to reduce the amount of hormone treatments that we have to give during prostate. And finally, one that we just opened is a national trial, not quite along the theme of de-escalation, but what we're doing is for patients with metastatic cancers, we're actually adding in treatments, either surgery or radiation, to try to improve the survival of these patients with metastatic cancer.
Mm-hmm. And Dr. Khan?
So I've been very fortunate to receive the support of the Cancer Center in designing and conducting my own clinical trials called investigator-initiated trials. So one of the trials that I have just completed is a trial of de-escalation. Mm-hmm. And in that particular trial, we are looking at giving patients endocrine therapy or anti-hormone treatment plus a targeted treatment, and seeing the response and looking at how many patients can avoid chemotherapy based on the response that we get from endocrine therapy. And this cancer center this trial was conducted in our cancer center and 10 other NCI designated cancer centers, and we were the lead institution in that particular trial. And we will be reporting the results of that particular trial in San Antonio Breast Cancer Symposium.
That's great.
Another trial that I'm very excited about is addition of a diabetes drug to the current treatment of HER2-positive breast cancer. So the trial itself is studying the addition of metformin, which is a diabetes drug with anti-cancer properties, and combining that with anti-HER2 treatment and chemotherapy, and seeing how many patients get complete response at the time of surgery, and based on that would have excellent outcomes from their early stage breast cancer. In addition to that, I am also close to completing another trial, which is I just mentioned before, which is the drug capecitabine or Xeloda, and we're looking at a different schedule and a much tolerable dose of Xeloda, and comparing that to the standard FDA-approved dose of Xeloda, and seeing if we we attain the similar outcomes and achieve similar outcomes without with much less side effects from the treatment.
So our audience may be interested to know that Dr. Khan, I think for the last 2 years, if I'm not mistaken, has been the leading accruer in terms of our clinical trials office. So congratulations.
Thank you.
On that. Kind of what would you like for our viewers to kind of take away from this morning's session in terms of de-escalation?
I think the future is incredibly bright. I think the landscape of prostate cancer treatments, all cancer treatments, is really changing. And I think we're finally at the point where we can take advantage of biology and understanding of genomics and biology to even better tailored treatments and allow us to do less dose or more convenient dose for patients. And I think things are only going to keep getting better.
Mm-hmm.
Yeah, the story of breast cancer research is thousands of researchers taking small steps and gaining incremental gains because of those small steps. And that research is mainly focused on finding novel treatments and targeted treatments and also de-escalation. So there is a subgroup of patients with HER2-positive breast cancer, and I think I would not be surprised if we see even stage 4 breast cancer cured in not so distant future.
Yeah. Exciting.
So Cameron, I understand we have a couple of questions from our audience. What's our first question?
Yes, we do. We have 2 questions, and the first question is, are BRCA positive patients eligible for de-escalation of treatment?
I think that is a great question, and yes, the answer is yes. So what we have learned is that the BRCA positive cancers, stage 4 BRCA positive breast cancers, are extremely sensitive to a group of drugs called PARP inhibitors, and those drugs, we have 2 phase 3 clinical trials that have shown that those drugs improve survival in patients who have BRCA1 positive cancer. And the reason I say it's de-escalation is possible is because those drugs have very few side effects. They are very targeted treatment and target only the BRCA1 positive mutation. Because if the person has a BRCA1 mutation or called a germline mutation, the cancer cells will also have the same mutation, and that mutation is targeted by this particular agent called a PARP inhibitor. The second thing that we have learned over the clinical trial and some of the data from our own cancer center is that the BRCA positive cancers are very sensitive to platinum agents. It's a type of chemotherapy with very few long-term side effects. But the addition of carboplatin increases cure rates in early stage breast cancer and increases survival in patients with stage 4 breast cancer. So that was an excellent question.
What's our next question?
And the second question is, what is the best way to approach your oncologist when interested in clinical trials de-escalation? What are the right questions to ask?
Wow. I think any clinical trial is just, you should always ask your oncologist if you have a clinical trial that's available for the patient. I mean, I think that's always a great option. Even if it's not a de-escalation trial, you should always find out what options you have.
Right.
I think from patient standpoint, I think what they should ask their oncologist is, what are the side effects of this particular treatment that you're recommending? And not only the short-term side effects such as hair loss or nausea, but also long-term side effects. For example, heart problems in the future, organ problems in the future, and also leukemias or blood cancers that potentially can be are not curable and very difficult to cure. And the follow-up question to that question is that, is there any substitutes or any other strategies that you have that might obviate the need for these agents with long-term side effects, and that would cover de-escalation as well. The other thing that we are learning about de-escalation through research is the duration of treatment. For example, traditionally for HER2-positive breast cancer, recommendation has been for 1 year of Herceptin-based treatment. And Herceptin is a very good drug, but it still has side effects. So the researchers in England have done a clinical trial where they have shown that 6 months of Herceptin may be as good as 12 months of Herceptin. So another way of de-escalating, shortening the duration of the treatment itself. So those are the questions that you need to discuss with your oncologist about the side effects, and also is there any way we can reduce the duration of treatments.
Well, Dr. Shen and Dr. Khan, thank you so much for being with us this morning. That's it for today. We'll see you next week at the same time. Thanks for watching, and good day.